Good morning, good afternoon, good evening, wherever you're logging on from. Welcome to the 2026, the Australasian Puro Seminars or TAPS. Today we're going to have an interesting case discussion led by Professor Ben Kwan from Sydney. So he's a chest physician with a strong Puro interest at St. Vincent Hospital in Sydney, and he also leads the Puro services in the Southland. And joining him is also his advanced trainee, Dr. Athi, who is going to help to present the case. So I won't give too much away about what it is. But as usual, if you have any questions and suggestions and comments, please type it on chat so that we can go through that afterwards. So without further ado, Ben and Athi.
Great. Okay, welcome everybody. Thanks. Thank you so much for joining us today, and thank you, Gary and the team, for inviting us to speak. So today we're going to present the case and have discussion afterwards. The title of the case, obviously, that we discuss is called "When Periods Take Your Breath Away." Hopefully, some of you may kind of get a clue as to what we want to talk about. So just a quick outline of our talk today. We'll just have a simple case discussion, and then we'll talk about the demographic of the diseases that we're going to present and the clinical finding and management approach, and then we'll have some time for discussion. So we're going to present Miss Athi, who is 42 by the time she presented to us. She doesn't really have much significant medical background history. She's G3, P3. They're all relatively natural birth, no artificial insemination history in the past. She's a non-smoker, besides a bit of mild OSA, no significant respiratory issues before, but was from time to time given salbutamol for breathlessness as a management tool. She has a history of heavy, painful menstrual period that she subsequently advises, but it wasn't particularly troubling for her, and she was not aware of any prior gynecological disorder. Her presentations first came to the surfaces, it was probably back in August 2024. At the time, she actually just fell off a stool about 1 meter height, but both sides of the under the armpit. And so it wasn't particularly traumatic, but she presented to the emergency department in one of the other sister hospital, and they felt that at that time they did a chest X-ray for the chest pain that she experienced, and subsequently you can see on the X-ray that's presented there was a pneumothorax on the right side. Suitably, she was managed as a potential traumatic pneumothorax with a small bore in the costal catheter. She did this for 1 week, and then there was sufficient for the trauma team to felt that there was a radiographic resolution and subsequently discharge. 2 weeks after that, she actually have a recurrence of right-sided chest pain. She felt that it wasn't as bad as before, but it wasn't as much breathlessness associated. A CT scan was performed again in the other hospital, and you can demonstrate that there is actually a moderate-sized pneumothorax that is present with a degree of collapse and atelectasis segment in the right lung. Of note, though, they do mentioned that there was presence of a pneumatocyst on the left lower lobe and possibly in the right upper lobe. So the trauma team that saw the patient before, she was readmitted under them, and they felt that this time round they would just conservatively manage the pneumothorax in case she was not particularly from the vital ops perspective was concerned, and she was actually still mobilizing and able to perform most of the duty, so they thought they would just observe her in the community. So by the end of September, her breathlessness has largely resolved, and same as her chest pain. The X-ray was done at that time, and this was the resultant CT scan, which I would like to highlight again the presence of pneumatocyst in the left lower lobe, as well as a pneumatocyst you can see here about 16 millimeter. And then there was also another one in the right upper lobe that was present before, which hopefully when we cycle through, we should be able to see it. The right upper lobe one was measuring probably about 3 centimeter or 3.5 centimeter by about 2 centimeter, and thought it to be remaining similar and stable in size. Present there, just this part here that I'm circling here. So then, time frame perspective, she remains relatively okay. for the year or so, besides the minor metacarpal surgery that was scheduled in September last year now, so about a year at the time. She went to hospital when she was there after the general anesthetic and after the surgery. Then she developed a degree of breathlessness, and that's when they repeated an X-ray, and it showed that demonstrated that this actually has got a pneumothorax that was present there. Then she elected and came across to our facility. She has got a CT scan demonstrating then the recurrence of this right-sided pneumothorax, moderate against small to moderate in size, again with stable presence of the two pneumatocysts that we can see there. And subsequently, our cardiothoracic surgeon took her to theater for a surgical approach to the recurrent pneumothorax, but also to do a FETS procedure to help resolve the pneumothorax as management. So we're now going to look at the histopathology, because when that was done, the surgeon's comment was that he felt that there was something not quite right on the pleura. There were certain spots that he can see. So they elected to not only took a little bit of sample from the pleura and some from the diaphragm where the spots were, but also managed to take a little bit of the right out for a wet resection to have a look. And this is the macroscopic view actually of the right upper lobe wet resection that he took. And so of this first glance that you can see there, there's definitely glands and stroma on lower on high power view that you can see in the presence. And this is in keeping with actually endometrial origin, because when they run the immunohistochemistry stain on it, there was PAX2 and PAX8, which are typical staining that we look for in both renal cells as well as endometrial or ovarian origin, and both of them were positive. This led to our pathologist started to consider whether this is actually a thoracic endometriosis. She then looked at the sample that was from the diaphragm, as well actually as from one of the pleural cysts that was there. And what she found was that similarly embedded within the wall of the cyst, there were all these stromal and glandular structure that was similarly stained for PAX8 and PAX2, as well as CK7, again, a typical marker that can demonstrate the presence not only just of, from the different tubular structure, but also coming again from the endometrial and ovarian origin. And then it was also ER positive. So a subsequent impression that this was actually she has got thoracic endometriosis and likely catamenial pneumothorax. She underwent a FET, and so far this has only been about 2 months or so. Her course was relatively complicated with just ongoing chest pain on the same side, which kind of helped subdue by the last review in December. But you can see besides slight loss of volume on the right side, there was no recurrence of the pneumothorax at this stage. So she's currently on an OCP treatment, waiting for a formal gynecological review for a possible pelvic endometriosis based on her previous menstrual cycle and menstrual symptoms, and a positive family history, actually her mother having endometriosis as well. So I'm going to pass to Athi to explain a little bit more about thoracic endometriosis, but especially about catamenial pneumothorax and effusion.
Thanks, Ben. So yeah, catamenial pneumothorax is a phenomenon which occurs in women of reproductive age, and they have recurrent pneumothoraces, which is usually within the first 72 hours of their monthly menstrual cycle, in the absence of other lung diseases. The mean age of onset is about 32 to 35 years of age, but it can develop as late as 39. It's actually been found to be the cause in about 3 to 6% of cases of spontaneous pneumothorax. And it is most commonly on the right side, with 85 to 95% being right-sided. The remainder is either left-sided or bilateral. It was first described in 1958, but the terminology catamenial pneumothorax was created in 1972. And there's a strong association between catamenial pneumothorax and thoracic endometriosis, which we'll discuss going forward. So this is an example of a couple of cases demonstrating catamenial pneumothorax, and you just see a right-sided pneumothorax on this X-ray. In case D, there is a couple of red arrows also pointing at a little bit of defects of the right-sided diaphragm, with catamenial pneumothorax often resulting in diaphragmatic fenestrations, and you can get the liver herniating through that, which can be seen on X-ray and often more clearly on CT. So as I mentioned, there is a strong association between catamenial pneumothorax and thoracic endometriosis, which is the presence of ectopic endometrial tissue within the thoracic cavity, on the diaphragm, the visceral or parietal pleura, or in the parenchyma itself. In terms of what thoracic endometriosis can cause, the most common is pneumothorax, which is about 72% of cases, followed by hemoptysis, pleural hematoma, or a catamenial hemothorax, and lung nodules as well. So catamenial hemothorax is not as common as pneumothorax, and this is an example of a case of it here. So as can be seen on the images on this case report, the patient presented with a pleural effusion on the right side once again, with an aspirate demonstrating high red blood cell count in keeping with a pleural hemothorax. The CT scan shows a large right-sided pleural effusion with the Hounsfield units on that CT being in keeping with that of blood. Now, there's also, so image B at the bottom right, the red arrow is pointing to a left ovarian cyst, and there was also a large adnexal mass close to the uterus and the left ovarian cyst, which was likely endometriosis. In terms of the diagnosis of thoracic endometriosis, now it is catamenial pneumothorax is usually a clinical diagnosis, but thoracic endometriosis should be confirmed by biopsy of the thoracic lesions. It would be defined as probable thoracic endometriosis if there's evidence of endometrial stroma on the biopsy, and proven thoracic endometriosis if there is evidence of endometrial stoma and glands identified on the biopsy. However, as can kind of be seen in this table here, catamenial pneumothorax and thoracic endometriosis can be mutually exclusive, and so one can exist without the other, and vice versa. And as I was mentioning before, thoracic endometriosis can result in the other presentations, including catamenial hemothorax. In terms of the investigations that we go through to investigate for catamenial pneumothorax, chest imaging would usually start with a chest X-ray for initial assessment, and we'd also look at a CT chest, and I'll go through a couple of examples in the next slide. CA125 is a non-specific marker, and it's usually just used as an adjunct. Levels of CA125 go up in endometriosis, and therefore they would also go up in thoracic endometriosis. It can be used to support the diagnosis, but isn't very specific. Gynecological assessment is highly advised for all of these patients because they will often also concurrently have pelvic endometriosis. So investigation for that with a transvaginal ultrasound or an MRI of the pelvis is recommended. So this is an example of a couple of investigations and imaging done for a case of thoracic endometriosis and subsequent catamenial pneumothorax. The CT scan on the left here, you can see nodules at the right diaphragm. And those nodules is because the thoracic endometriosis has resulted in fenestrations forming of that right-sided diaphragm, and the liver is herniating through those fenestrations. That can also be seen on the X-ray in Figure 2, and Figure 6 gives us a view of what it looked like surgically. So moving on, we're just going to quickly discuss the pathophysiology behind catamenial pneumothorax as well. So there are multiple theories which have been suggested to explain the pathophysiological mechanism, and we'll go through these. In reality, there's probably multiple of these mechanisms occurring at the same time to cause catamenial pneumothoraxes. Both of these images here demonstrate the diaphragm, and you can see on the left side there are what we think are chocolate cysts after the deposition of a thoracic endometriosis. And on the right side, you can see fenestrations um, of the diaphragm, which are key in the cause of catamenial pneumothorax. So in terms of the first theory, the first one is the microembolization or metastatic theory. And this theory is dependent on ectopic endometrial tissue, which reaches the lung via the venous circulation or lymphatic channels. This endometrial tissue is going to undergo inflammation and bleeding during the menstrual cycle, resulting in the formation of chocolate cysts in some cases, which is what we saw previously. The ectopic endometrial tissue does not have the support of the normal vascular architecture and hormonal regulation that the uterine endometrium has. And as a result of this, the menstrual cycle results in more uncoordinated ischemia within the ectopic endometrium. This is going to result in the formation of fenestrations and defects in the pleura, the diaphragm, and within the parenchyma as well, where the endometrial tissue is sitting. As a result of this, we're going to get the formation of pleuroparenchymal fistula, resulting in catamenial pneumothoraces, as well as the fenestrations in the diaphragm as well. Bleeding can also occur into the airways directly, which will result in hemoptysis, or bleeding could occur into the pleural space, which could result in catamenial hemothorax. The next theory which I wanted to discuss is the migrational theory, which describes another way through which the thoracic endometriosis may form. So as described previously, most of the time the pneumothorax and the thoracic endometriosis occurs on the right side. And the theorized reasoning for that is the peritoneal fluid tends to flow in a clockwise manner, and this can cause abdominal endometrial tissue to be pushed up onto that right side, resulting in right-sided thoracic endometriosis. And this theory kind of states that the endometrial tissue spreads directly from the abdomen to the diaphragm and then onto the pleura, with the hormonal changes resulting in fenestrations and ischemia, as I previously described. Yeah. Finally, there's also a hormonal theory or the prostaglandin-mediated theory. And this theory is dependent on the hormonal changes which occur during menstruation. And this one is specifically giving a theory as to why catamenial pneumothorax might occur even without the presence of thoracic endometriosis. So what this theory states is that the withdrawal of progesterone observed during menstruation results in an increase in prostaglandins. Now, prostaglandins is going to cause potent bronchiolar constriction and pulmonary vasoconstriction as well, which could result in alveolar overdistension and subsequent rupture, resulting in the pneumothorax. However, most published articles often mention that this theory is likely insufficient on its own to cause catamenial pneumothorax, but could be playing a role as well. Moving on to the acute management. The management of catamenial pneumothorax is difficult due to the high rates of recurrence of pneumothorax, but acutely, the management is quite similar to that of other secondary spontaneous pneumothoraces. The options that can be considered are conservative management with observation supplemental oxygen, needle aspiration when there's no evidence of tension pneumothorax, intercostal catheter for larger ones, and there is a role for emergency decompression if there is evidence of tension pneumothorax. But as I mentioned, the key part of managing catamenial pneumothorax is preventing recurrence. So as we can see in this table, if catamenial pneumothorax is treated with just an ICC, recurrence rates are up to 50%. If surgery is performed, recurrence rates are still 20 to 30%. Hormonal treatment alone, it's 25 to 50%. And it's only when we combine surgery and hormonal treatment that recurrence rates drop below 10 to 15%. As a result of this, it's very important that we manage catamenial pneumothorax in a multidisciplinary team involving respiratory physician, cardiothoracics, and gynecology to help guide management. In terms of the surgery that we want performed for catamenial pneumothorax, it should always be a VATS-based procedure, and multiple anatomical targets should be addressed during this procedure. So how these procedures generally start is there's a thorough inspection of the visceral pleura, parietal pleura, and most importantly, the diaphragm. Diaphragmatic disease is the biggest indicator of recurrent pneumothoraces, and therefore any fenestrations or endometrial implants should be acted on. Involved areas of the diaphragm should be resected and can have primary repair or patch repair or even mesh repairs completed. In terms of the lung parenchyma, blebs, nodules, and endometrial implants should have wedge resections performed to reduce the chances of pleuroparenchymal air leaks. And for the pleura, any evidence of thoracic endometriosis should also be removed. They can also be considered for talc pleurodesis and mechanical pleurodesis during the procedure itself as well. Following the surgery, patients should be started on hormonal therapy, which ideally should be driven by our gynecology colleagues. And what should definitely be taken into account is the patient's plans about pregnancy. What we are aiming to do with this hormonal therapy is induce a hypoestrogenic state and suppress ovulation to cause atrophy in the ectopic endometrial tissue, which ideally should prevent cyclical tissue injury and prevent recurrence. The first-line therapy is the combined oral contraceptive pill, which is taken continuously to put a woman in an amenorrhoeic state, or progesterone-only oral therapy. Second-line therapy is GnRH agonists, and as mentioned earlier, gynecologists should also look for pelvic endometriosis and treat that if required. So in terms of the key learning points regarding catamenial pneumothorax, so it usually results in recurrent right-sided pneumothorax in women of reproductive age. And it should be thought about as soon as if there's a patient who fits that criteria, we should be thinking about that. Diagnosis, however, is clinical and it's often delayed, and optimal management requires both surgical and hormonal therapy, with multidisciplinary collaboration being essential.
Great, and that's the end of our, and these are references and end of our presentation of our case and a quick run through about breast endometriosis.
Great, thank you both. That's a very good presentation. So I'll encourage the audience to type in any questions in the chat room. But while we're waiting for that, I think it is a very important thing for clinicians, including pulmonologists, to go and realize this. I think I've seen a lot of cases where the diagnosis is missed even by pulmonologists, and a lot of misinformation was given to patients. And I do distinctly remember the first patient I saw back in Perth with this is the pulmonologist who referred her said that she's probably drug seeking and doing self-harm each month or something like that. And that's just not very fair for the patient. Now, my first question is, what do you do when the patients come in and say they want to get pregnant? That's often when they're stabilized on hormonal treatment and now you have a problem.
So certainly it has been published before that when a patient go back into pregnancy, there's a potential risk that the catamenial pneumothorax can occur or recur, and it can be life-threatening. So of course, if it does happen, then it needs to be managed as any kind of acute pneumothorax situation. But before the pregnancy, or I suppose whilst planning for the pregnancy, that's that part where the MDT is important to discuss between the respiratory physician and the gynecologist to start looking at hormonal therapy or psychotherapy to see whether or not can come out of or come off the OCP and go into the GnRH. Like people, going for potentially artificial insemination cycle, similar kind of approach to that. But then explain to the patient that whilst the literature suggested the risk is very low, so there were some instances that only a few out of 30 to 40 cases can recur during the pregnancy. It is real and it has happened. So so I think it is about proper planning and monitoring during the pregnancy for the patient, and then afterwards, then reconsideration of going back into hormonal therapy. Yeah.
So, question from Donnie from New Zealand. What is the best timing for surgery in terms of do you time it to the period cycle for the patient?
So that's a very interesting point. So there was a very interesting article written by one of the surgeons that says that to find the tissues sometimes is not easy because they are very small minor deposit. And in our case, at first glance, the surgeon actually didn't even recognize it. That she just said that it looks like something not quite normal on the pleural and the diaphragm surface. He couldn't tell, so that's why I took a wedge and took sample to have a look. So the surgeon in the report published online actually suggested that should time it to the menstruation, so then you can actually hopefully can visualize the endometrial tissue better and therefore can more radically eradicate or remove as much as possible. But I haven't met enough surgeons that actually have looked after cases like this to get their approach as to whether that is really true or not. I think most of them would just say, look, if it happens continuously, they would just treat it, irrespective so much of the cycle, with the understanding that hopefully after surgery, they should then go on to hormonal therapy rather than just surgery alone.
Yeah. And I think that raised a very important point is that a lot of surgeons also are not very aware of this and they don't look for these kind of signs. And then I think they are, for example, when I come back to Perth many years ago, we talked to our thoracic surgeon, and since then, he has identified a lot more of these menstruations in patients that we were not even suspecting of endometriosis in young female, especially with right-sided disease. And I think we have had one patient where when we did the CT scan, we just happened to actually catch a little drop of air below the diaphragm on the right side that help us to support the thinking that the air comes from the abdomen rather than from the lung itself. But again, appreciate that there are many different hypotheses and theories that we don't entirely know. But there's no question that it is right-sided predominant. That's absolutely true. Now, one of my patients from overseas had multiple pneumothoraces, and then she said that from her home country, they have discussed with her that she might have catamenial pneumothorax. But because she does not have it every month, then her doctors in that home country said that cannot be catamenial pneumothorax. What do you think about that?
So, if you look at the literature, it is a clinical diagnosis. While it is usually preceding or menstruation period, it doesn't necessarily has to be the case. And often, it actually can be missed because it could be actually a few days before, or even a few weeks before, or even after. So it can happen outside of the usual kind of cycle. I think it is really a matter of basing on the clinical history, like in this case, and then having think in a young reproductive age woman, and then have to think about, well, what are the other likelihood of of recurrent pneumothorax, and then probably a much more early discussion about a surgical approach via FETs to help the diagnosis would be more, but I wouldn't base just on the presence or absence around a menstrual cycle as the clinical diagnosis.
Yeah. Again, we'll encourage anyone who wants to put any questions on chat, but I'll keep asking questions if not. We do find that there's quite a lot of patients who cannot tolerate the hormonal treatment. And we did send them to vets, but it's not always successful. Do you feel that vets has a higher failure rate for people who've got catamenial pneumothorax?
So I think the literature would suggest that FETs alone is not so easily the answer. Really should be a combination modality approach. But of course, if the patient cannot tolerate hormonal therapy for very good reason. Then, from surgical perspective, then there is this risk, right, up to about 20-30% at least, that they may recur. And I think, the important thing then is to have a management plan and a recurrence to monitor the patients forward, and then to have this continuous discussion with both the surgeon and the gynecologist and the patients about what to do if truly they keep coming back. And we can't look at the hormonal therapy. Then do we look at the second line GnRH? What do we do to try to remove the recurrence?
I think in Australia at the moment, to access the luteinizing hormone reducing hormone antagonist, we have to have biopsy proven endometriosis, which is obviously difficult if they only have diaphragmatic fenestrations, and that was one of the limitations that we have with some of the patients. Yeah. All right, so I think we've actually about 5 minutes over time, so we might just stop here. And I'd like to thank Ben and Athi again for a very informative presentation. And I want to take this opportunity and introduce that this year, starting 2026, we will probably going to have a lot more educational activities, including probably 3 times a year to 4 times a year journal club. I think most of the young people don't like reading literature, so they want it to be pre-digested for them. That's what it's going to be. And also a difficult case meeting, like an MDT. So, but sticking to the TAPS presentation, so first week of February, the next presentation is about genetics of pneumothorax. So staying on with pneumothorax, but about genetics, and it's going to be by Professor Stefan Marciniak in Cambridge, who is one of the leading person to start having pneumothorax clinics in the UK, which is a growing service. So I would encourage you to dial in on the first Wednesday of February. And till then, take care, and then we'll see you soon. Bye.